So, not sure, sir. Hunter, sir.
Yes.
So, as edge.
So is John Hunter. So
Good.
next.
Right.
Now, let's come to a scenario. 60-year-old gentleman came to OPD with complaint of sudden onset swelling in weeks, which increases in straining and reduces in lying down. Okay, this is a simple answer, so I am giving you the answer. Right side incomplete inguinal hernia. So next question will be a very simple. Define hernia.
Sir, hernia is it is the abnormal protrusion of the wall or the abnormal protrusion of a part or a complete viscous from the wall of its containing cavity.
So next slide. So so it is the answer which has already been given. Next. So I am just completion of the chapter. I am giving you the differential diagnosis of inguinal hernia. Whenever you are asking about the differential diagnosis of inguinal hernia, so these are the.
You see, when you give a differential diagnosis, you rely on your clinical finding. Suppose you find it's a scrotal swelling, then it cannot be hernia. If it is inguinoscrotal swelling, and in that case, you cannot keep being a diagnosis of vaginal hydrocele. Some hydrocele which extend from the scrotum to the groin, internal hydrocele or conjugal hydrocele can be a pure vaginal hydrocele cannot be DT for a patient of inguinal hernia. Second is undescended testis. If you find both the testes are in the scrotum, then you cannot bring a DT of. So all will depend. This is the list which are possible in a groin and inguinoscrotal swelling. But you should bring the diagnosis which will be closely clinical test.
Next.
Giving a differential hydrocele, the most common question comes next is.
Sir, like you pointed out, hernia and hydrocele. Hernia would be an inguinal swelling, whereas the hydrocele would be purely scrotal swelling, sir. So the first test that we can do is we would try to get above the swelling. In case of an inguinal hernia, we would not be able to get above the swelling, but in case of a hydrocele, we will be able to get above the swelling. So next would be we can do the transillumination test, sir. In case of a hydrocele, the transillumination test is possible, whereas in case of a hernia, the transillumination test will not be possible. Also, sir,
before transillumination. Before transillumination.
Sir, contents, sir, we can try to reduce the contents. In
Yes.
case of a hernia, we'll be able to reduce the contents of the hernia, but in case of a hydrocele, that will not be possible. So also, if it is not a complete hernia, we might be able to feel the testes and the epididymis. We might be able to palpate the testes and the epididymis separately in case of a hernia, but in case of a hydrocele, that might not be possible.
Now I'm interrupting you and telling you something once. Many examiner ask that what are the two cardinal features, clinical features of hernia? Your answer will be, if this is asked, you will say
cuff impulse and reduces
some modification. Reducibility is all right. It is not cuff impulse. It is expansive impulse on cuffing. So this should be the answer. So now, can you identify the region? This is the anatomy.
What region is shown in the picture? First region.
This is in one canal.
So I have put some arrow.
deep ring and the Hasselbalch triangle.
Is the screen visible? Can one of the participants please reply?
Yes, sir.
Oh.
So what is that structure which is going from a vessel towards the rectus sheath? No?
No, this is not.
This is shown little medial, but consider this little lateral to that and on the medial boundary of the deep ring. This is inflexive vessels. What is C?
Oh, C is a spermatic cord.
Yes. What are the contents of spermatic cord? Come on this side. Yes, yes. Answer this.
This you have already answered. So,
Yes, so D is the anterior superior iliac spine. E is G is the inguinal ring, and F is the deep inguinal ring. E, I'm not
okay.
E is the origin of the.
I think D should be iliac crest, and if you follow the iliac crest, the lower bony point is anterior superior spine.
Just go for the next slide. This is the okay. So next question will come as what is the boundaries of inguinal canal? First option. So I am not going into details. You have already almost identified it. So
Okay, let's just discussion. What is the boundary of inguinal canal?
Sir, the roof is formed by the arched fibers of the conjoint tendon, which is the interior the part of the posterior wall, sir. So then anteriorly the external oblique will be there. We have the Cooper's ligament and
Try to understand. Cooper's ligament doesn't come in the boundary inguinal canals. It is part of in extent from the deep ring to the superficial ring. First. Second is if you study the roof is formed by conjoint tendon. Floor is formed by the inguinal ligament and medially by the lacunar ligament. And if you go to the posterior one, is formed by primarily fascia transversus throughout and partly by conjoint tendon. Anterior boundary
external
plus if you read belly lab, nicely written. Is external oblique throughout, medially reinforced by the conjoint tendon, because conjoint tendon comes anterior to the cord medially. Okay, what is the next? So boundary. So this is a boundary. Describe. Read it. Just read it up.
Walls of the inguinal canal. Anterior wall is formed mainly by the aponeurosis of the external oblique.
Reinforced by conjoint tendon medially.
Posterior wall is formed mainly by the transfer. Roof is formed by the arching fibers of the internal oblique and the transverse abdominis muscle. And the floor is formed by the middle part by the lacunar.
So you see, answer has to be very precise. If there are 2 marks being earmarked for this, if you make one mistake, you'll lose half marks.
Next, what sir have already asked? What are the contents of
It's of course.
Back for that.
So next is the content. If I ask differently, what is the relation of the illuminal nerve to the deep ring? The contents of the cord come right. What are the contents of the somatic cord? What are the somatic cord contents?
So the So it will branch the genital
And artery to the vas.
femur.
And what are the
Mapunda.
coverings of spermatic cord at this level? Yes, yes,
Mapunda,
madam. Yes, yes, madam.
কিচ্ছু শোনা যাচ্ছে না, কারোরই আওয়াজ শোনা যাচ্ছে না।
তাই?
হ্যাঁ, আরেকজন
আচ্ছা।
সুভাষ গুপ্ত একই জিনিস লিখেছেন, কিচ্ছু শোনা যাচ্ছে না।
না, দেখছি ম্যাডাম, দেখছি। Just a minute. What about other participant? Komal, you can hear us?
Sir, there is lagging in video and audio, sir.
Huh?
Sir, there is lagging in both audio and video, sir. It's difficult to hear.
Is the connectivity better now?
Komal, you can hear us? Komal?
Yes, sir, I can hear now.
Is the screen?
Yes, sir, the screen is visible now.
Audio?
Sir, there is
So you have discussed
still some lag in the
inguinal
audio.
canal. You see, in the exam, what we have shown you a picture of inguinal canal, and inguinal canal first you may have some marking with the structure being shown there, and then the few questions maybe what are the boundary inguinal canal. Then there can be a question on this. Suppose I have gone through this part and then asked what is shutter mechanism in inguinal canal? What is shutter mechanism in the inguinal canal?
So basically on increase of the intra-abdominal pressure, the superior inguinal ring, sir, it is in the shape of a triangle,
Okay.
and so that it's the two flaps close to prevent
Which two flap closes?
So
Because one there is a contraction.
Yes.
One there is a contraction that it pushes the posterior wall because it is a part of the posterior boundary.
Yes.
Similarly, in the medial part, the conjunction is there. That pushes posteriorly. So these are shutter mechanisms. You have two structure, same structure forming both posterior and anterior wall. When it contracts, it squeezes and compresses both the walls. So that prevents formation of
hernia. Then we come with the contents of the spermatic cord.
So these are shutter mechanism.
So what are the contents of inguinal canal? Next.
So should I read this?
Just read.
The spermatic. What are the contents of the inguinal canal? Firstly, we have the spermatic cord. In the case of females, we'll have the round ligament of the uterus. The cord itself, the contents are the vas deferens and its artery, testicular artery and the pampiniform plexus, genital branch of the genitofemoral nerve, lymphatic vessels and sympathetic nerve fibers, fat and connective tissue surrounding the cord and its covering in the various amounts. Secondly, we have the ilioinguinal nerve and the ilioinguinal lymph nodes.
Now, there is some overlapping of questions. Some questions can be asked earlier than this. So, I have trying to maintain some order. What are the differences between direct and indirect hernia? Or how will you differentiate between direct and indirect hernia in a clinical examination? History and clinical examination from.
You can change.
So question is, from your history and clinical examination, how will you differentiate whether it is indirect or direct hernia?
Because these are very specific answers. In the exam, you say it's indirect hernia, and then next question is how do you differentiate from direct hernia? So what are the usual points in history and the examination part?
From the history, sir, the indirect hernia will be, sir, complete.
No, I don't start with that. Start with the patient profile. Start with the size.
Sir,
Direct hernia is common in younger age group or elderly age group. So elderly age group, direct hernia is common. Size.
Which side?
Indirect hernia is common on one side, unilateral.
Yeah.
If the hernia is bilateral, it may be indirect. Even indirect hernia may be bilateral. But point is, you are citing some points to have some idea whether it is a direct indirect. We are not confirming it is. So bilateral. Then
From the history and just clinical
in clinical examination,
first is inspection.
clinical examination, what do you find?
First inspection.
Which hernia inspection, which hernia is more likely to be complete?
Sir, indirect hernia.
Indirect hernia more likely complete. Yes. When the patient coughs, if you look at this cough impulse, does it make a difference?
Yes, sir.
What?
Sir, cough impulse, sir, if it is indirect hernia, sir, it will be more lateral.
More? The cough impulse will go downwards.
Downwards. And sir.
And downwards and forwards. And in direct hernia, it will be just forward bulge.
Yes.
Then?
So then, sir, on examination, sir, we'll do deep ring occlusion test.
Yes.
So it will be positive in indirect hernia. And so.
Yeah. Deep ring occlusion is all right. Don't say invasion test.
Never tell.
What is the area through which a direct hernia comes out?
So it comes from the Hasselbeck triangles.
What is the boundary of Hasselbeck triangle?
Sir, medially, sir, it is lateral border of rectus muscle.
Not muscle, it is rectus sheath.
Sir, laterally it is inferior epigastric vessels.
Yes.
Sir, below sir, inguinal on the knee.
Yes.
So just two things you have to can add, though it is purely theoretical. Somebody is written in the book that on inspection, direct hernia is almost globular in shape. It is piliform or pear-shaped vertebra with that called indirect hernia. Number two, one catch patient again. So in which side hernia is common? Which side hernia is common? Why?
Sir, because the obliteration of processes
occurs late in right side. So there are some examiner ask these questions in MS exam. So next. So this is the. These are already done. So this is the difference between.
Just read out. What is that?
The age indirect hernia is more common in children and young people. Direct hernia, aged people. Pathway of protrusion coming down the inguinal canal may enter the scrotum. Indirect hernia pass through the Hasselbeck triangle, rarely enter the scrotum. Contour of the sac in indirect hernia, elliptic, pear-shaped, direct, semispheric, wide base. Deep ring occlusion test is controlled after reduction by pressure over the internal deep inguinal ring in the indirect hernia. Not controlled after reduction by pressure over the internal inguinal ring in direct.
So it's simple, not as you say. Deep occlusion is positive.
Positive.
A relationship of spermatic cord with sac. Indirect hernia posterior to the sac, and indirect hernia anterior and lateral to the sac.
That's why that cough impulse comes like that.
Relationship of sac neck with inferior epigastric artery. Sac neck is lateral to it. And in indirect hernia, sac neck is medial to it.
What? So can you identify the test? Right. Already mentioned. I did not come with the video. No, can you describe? Anybody can describe how will you perform deep ring testing? It's a very common question to ask.
What are the steps to do deep ring occlusion test?
The patient in supine position, so we have to reduce the hernia.
Yes. The first criteria, hernia has to be reducible to do the deep occlusion test. So patient is lying down, reduce the hernia. Then
we have to mark the deep inguinal ring.
Describe now. This is another question. How do you mark the deep inguinal ring?
Sir, it is sir, 2.5 centimeter above the
2.5.
sir, 1.5
Mm.
centimeter above the mid-inguinal.
How do you find that?
Sir,
How do you find the mid-inguinal point?
sir, it is sir, it is a medial point from the anterior to the pubic.
Yes.
Uh,
You see, the exam, there is some confusion about it. You find the anterosubiliac spine. You find the symphysis pubis. Place a tape. And the mid point in this tape is the mid-inguinal point. But that point is not on the line of the tape. This point has to be placed on the groin crease on the inguinal ligament. And from there, you go. If you on this tape line, higher up. The mid-inguinal point is on the distance. That mid-inguinal has to be inguinal ligament is. And from there you go 1.27. And then what do you do?
so then deep inguinal ring, sir, we have to obliterate the deep inguinal ring and apply to cuff. If the
What precaution you should take when you occlude the deep inguinal? What you should ensure that you have occluded the deep inguinal ring? You should not place your finger which will encroach in the Hasselbalch. So place your finger in such a way that you are occluding on the deep ring, not encroaching onto the Hasselbalch. And then
the patient is asked to cuff, the swelling appears, then sir, it is direct hernia.
suppose on pressing, you are right, you press and then there's a bulge on the medial side. The test is done. You say deep infiltration is negative because there is a bulge in there. There is no bulge. Do you do anything else now? A small direct hernia may not bulge on lying down.
So then,
Keeping the deep ring occluded, you have to ask the patient to stand up and then cuff again. So you don't stop. If the bulge is seen, it is done. If the bulge is not seen, keeping the deep ring occluded, you ask the patient to stand up and see whether there is a bulge or not. Okay. Next.
Next, another test is, though it is not done routinely,
Yes.
but for theoretical purpose, if know
What is the test shown?
so this is creeping.
What is that test called as? This is Zeeman test. Although Zeeman test is not practiced and it is difficult to interpret the finding by placing 3 fingers, so it is not routinely done. So next.
So next we'll be asked about Nyhan's classification. I'm just giving the answer. So next. So there are the different procedures, questions. No. 2 videos. First. So not casting the name of the operation.
Okay, at the same time, put some question. What layer is now divided? What is this layer? In the inguinal canal, you have to divide one layer. What is the layer being divided to get into the sac?
Cremaster.
In the inguinal canal, the first is external spondy fascia is not the inguinal canal. External spondy fascia comes beyond the subition. So, yeah, this is the layer. You see, this is the cremaster fascia, which has to incise to get into the hernial sac. How will you identify the hernial sac?
Sir, hernial sac, sir, it will be sir white.
Yes, shiny white margin is a hernial sac.
Next is, what is the limit of dissection? How long?
Sir, dissection will be sir till the deep inguinal ring, sir, which is identified by the sir
till the extrapyramidal fatty tissue appears.
Yes.
Next.
What is the point to identify the neck of the sac?
The neck of the sac. The collar of the fat.
One is collar of fat pad around the neck. Number two, this is the constituted part of the sac, and if it's indented hernial sac, what do you find middle to that? Inferior vessels.
Inferior
So here are
epigastric
3
pulsation.
points to identify the neck of the sac. Is a constituted part. There is a collar of extraperitoneal fat pad around the neck, and you find the inferior vessel crossing the neck of the sac. What is this step? You are taking some suture from the upper border of the mesh to which part?
To the pubic tubercles.
Upper is pubic tubercle is more medial and then inferior. Upper is where? Conjunct tendon. Okay.
Yes.
Where is the fixing to the medial margin of the mesh? Where? Rectus sheath. Medially, mesh is fixed to rectus sheath. Inferiorly fixed to inguinal ligament above to the conjunct tendon. What you do in the lateral end of the mesh?
Sir, sir, at the lateral end, sir, we fix the.
No, lateral end is what?
Split.
Oh, you have to split.
Split the mesh.
Fish telling. So you have to split the mesh to accommodate the deep inguinal ring. Okay.
So, what is the name of this operation?
Like incision method.
Yes.
Next. The principle all been told is the tension free. What are the things, and we have to try to place the mesh as far as possible to cover up the weak points. That is, the medial most part should be covered. Next. So, what is this operation? It is the pictorial thing, and cannot find out anything from the just approximation. It's done here.
The sutures is taking what?
Ligament.
Is a interrupted suture taking bites from the conjunct tendon, first transversalis, and the below is the inguinal ligament. So what is this repair? Is modified patient is repair. Okay.
Yeah.
I think next Kamal can come up. Kamal, we will have some anatomic question left.
Yes, sir.
Okay. So in the groin,
Yes, sir.
we have some hernias which are not now defined only as inferior direct. What are the hernias in the groin?
Sir, inguinal hernias and femoral hernias, sir.
Yes. And inguinal hernia, we have direct, indirect.
Yes,
These hernias,
direct and indirect.
these hernias come through a common space in this region. What is that space described? Okay, come.
Yes, sir. Sir, the myopectineal orifice of Fouchard, sir.
Okay, come to that later. So you see, this is another operation for hernia, where there are serial layers being sutured. What is that operation called as? You see?
Sir, this is shoulder repair, sir.
Yes. So what is the original shoulder repair? How many layers are there in the original shoulder repair?
Sir, sir, there is a double
talk of
breasting
original
of the
shoulder repair. That is how many layers?
Three layers, sir.
No, 6 layers.
6 layers. Everything.
Original shoulder repair is 6 layers repair. Okay. So if you start with the deepest part, 2 layers, conjunct inguinal ligament 2 layers, external be 2 layers. So what is the modification?
Yes, sir.
Modification
What is the modification? Now what?
Name one surgeon who by him which name one of the modification goes. One money by Boyd's. Okay. So this shoulder repair has been modified, and people are sometimes now going to 3 layers. What is the advantage of this shoulder repair? this Schuldis clinic promote this repair and they have their own points. What is the advantage of Schuldis repair?
Sir, there is no need for a prosthetic mesh placement.
Yes, no prosthetic mesh, and they claim that their recurrence rate is less than 1%.
Yes, sir.
That is the advantage. What is the disadvantage for the people who are not doing Schuldis repair? What is their point? The point is, you see, what are you doing? You are double breasting all the layers.
Tension free. It's
yes. So
not
in the
exactly
principle hernia repair is tensionless repair. But if you keep on doing double breasting, there may be some tension in the suture line, number one. And if you see the layers and you are using too much suture materials, these are all non-absorbable suture materials. So if you go by 2 layers, you are using too much. You are using excessive suture materials. So that is against the basic principle of hernia repair. But still, people in the Schuldis clinic, they are using this technique till today. And another point is, the Schuldis repair is done under which anesthesia in the Schuldis clinic? What is their technique?
So local anesthesia.
Schuldis clinic people are doing it under local anesthesia. Great. They don't use even regional anesthesia. This procedure is done under local anesthesia.
No,
several meta-analyses have been done, and it has shown that the outcome of results is far lagging in other centers than Schuldis.
Yeah.
That is the main.
People cannot replicate the Schuldis clinic results. They are claiming that they have very good result with this repair, and they are still practicing. Next.
Principle has been told. Yeah. Now, this is the main thing which is talking about. So what is the region? Identify with the diagram, the main anatomic region or main anatomic landmarks. So first you just see.
Sir, this is the.
This is just not only the myofascial orifice. See, this is the area of the groin, part of the lower abdominal wall. Okay, so if you go by that, this is not only the inguinal area.
So this is both inguinal and femoral regions with the myopectineal orifice.
Okay, can you identify the structures marked with A, B, C, D? What is A?
Yes, sir. Sir, A is the rectus abdominis muscle, sir, covered by the rectus sheath.
Yes,
B will be, sir, inferior.
Sheath.
Yes, sir. Sir, inferior epigastric vessels.
Yes, good.
C will be the arching fibers, sir, of the transversus abdominis muscle.
And supervision is
D
what?
will be
C will be transversus abdominis and supervision to that. If you look from the surface, anterior surface, arching fibers of internal
oblique and transversus abdominis, sir.
D.
Transversus abdominis. D will be, sir, the aponeurotic arch at the lower end, sir.
This should be the deep inguinal.
E will be.
You see that D will be the deep inguinal ring through which the stomach vessels are coming out. Then.
Yes, sir. The gap is the deep inguinal ring, which is covered by the aponeurotic arch, sir. And E will be, sir. E will be, sir, the spermatic vessels.
Yes.
Sir, the internal spermatic vessels, sir.
Gonadal vessels. Then H, which is, if you take this in the pelvis, it is turning medially.
Sir, H is vas deferens, sir.
Vas deferens, yes. And what is F and G?
Sir, F is the inguinal ligament.
Good.
And
if I mark another thing, F1 here. If I mark F1 here, what is that?
Sir, that will be the lacunar ligament.
Good. And G is?
Sir, G is the ramus of the pubis, sir.
And covered by a ligament.
Sir, Cooper's ligament.
Cooper's. If you trace the Cooper's laterally, where does the Cooper ligament ends? If you trace the Cooper's ligament, then the femoral vessels comes. Where does the Cooper ligament ends? it ends at the femoral sheath. When the femoral vessels come from the Cooper ligament ends at this point, get blended with the femoral sheath. Okay, so beyond femoral sheath, there is no Cooper's ligament. Okay.
Yes, sir.
Next.
Yes, sir.
So next question will come. What is the boundary of Marpectoral orifice?
So now the groin hernia is said to come through this common weak area in the junction area of the abdomen and the thigh. That is a groin. So boundary is?
Yes, sir. Sir, the boundary, sir, medially it is the rectus abdominis muscle.
Sheath.
The rectus sheath, sir,
sheath.
medially. Yes, sir. Sir, superiorly it is the
medial and then come lateral.
Sir, laterally the iliopsoas muscles.
Yes. Roof
Sir,
for
laterally it is the iliopsoas muscles. Above, sir, it is the conjoint tendon.
And the arching fibers. Conjoint and the arching
Sir,
fibers, which is the large area.
The arching fibers, sir.
Yes. Then?
Yes, sir.
Floor or below?
And the lower boundary is the pecten pubis, sir, the Cooper's ligament covering the pecten pubis, sir.
Yes, good. If you take this whole area, this area is bisected by one structure. What is that?
Sir. Sir, the inguinal
one structure bisects this
transverse
area
structure.
into a posterior compartment and the anterior compartment.
Sir, the inguinal ligament.
Good.
Yes.
What structure passes in the posterior compartment?
Sir, in the posterior compartment, the spermatic cord will pass, sir.
No, no. Posterior is what? Behind the inguinal ligament.
Oh.
Got
Sir,
my
the
point?
femoral
Yes. Extrailiac vessels becoming femorals. Okay, and the femoral nerve going
yes, sir.
lateral to that. And iliopsoas coming behind the inguinal ligament. To the where does the iliopsoas muscle get inserted?
Yes, sir.
Where?
Where is the insertion of iliopsoas muscle?
Sir, on the
Which area of the femur?
sir, the origin is from the
I said
sir,
insertion.
the greater trochanter of the femur, sir.
No, no. It's in the lesser
Greater
trochanter.
trochanter, sir.
Lesser.
Lesser trochanter. Okay.
Lesser femur. So this is another anatomy which is seen in laparoscopic view. Okay.
Yes, sir.
It's seen in the laparoscopic view. So what is the structure A?
Sir, A is the inferior epigastric vessel, sir.
Good. What is structure shown as B?
Sir, B is the testicular vessels.
Yes. If I mark this, what is this?
Sir, the white structure that is turning, that
Yes.
is the vas deferens, sir.
No, not this one. This one. The one shown
Extreme
by
left.
the cursor. This one.
Okay, sir.
This should be medial umbilical fold or
Sir, the
medial
median
umbilical
umbilical
ligament.
medial umbilical
Which
ligament,
structure
sir.
is there deep to this fold?
Yes, sir.
What structure is there deep to this fold?
Sir, the obliterated urethra, sir.
That is the
median umbilical ligament. Obliterated urethra
Yes,
is the median umbilical ligament. If I say it is the
medial.
medial umbilical ligament, that is the
Sir, obliterated umbilical
artery.
obliterated
You find there is
umbilical
a
artery.
hernial gap. What is this hernia? Direct or indirect?
Sir, this is medial to the inferior epigastric vessel. It is lying inside the Hasselbalch triangle. So this is the direct hernial gap, sir.
If you go from behind, I will not call the Hasselbalch triangle. I will term this area as some inguinal fossa. What is this inguinal fossa? If you take these three structures now,
sir, the
median umbilical ligament, medial umbilical ligament, and lateral umbilical ligament. So you have three raised folds. And in between these three folds, there are some area now being marked. What is the area between the median umbilical ligament and the medial umbilical ligament? What is that area called as? Area posteriorly from laparoscopic view. Area between the median umbilical ligament and medial. What is the area called as? That is known as?
Sir, the medial inguinal.
No. Confined more medially. Area between the median umbilical ligament and medial. That area is known as supravesical fossa. Clear? Supravesical fossa. Now,
Yes, sir.
between the medial and the lateral umbilical ligament, what is this area called as? This is known as medial inguinal fossa. Hasselbalch triangle is seen from anterior.
Okay,
This
sir.
is described as medial inguinal fossa,
Yes,
and
sir.
hernia through this is called as a direct hernia. And what is the area lateral to the infused vessel?
Yes, sir.
That is lateral inguinal
So the
fossa.
lateral inguinal fossa.
If you take this structure now, what if you see the, you cannot see the inguinal ligament from interior. If you raise the peritoneal flap,
Yes,
you
sir.
see a dense fascial layer going along the inguinal ligament. What is that fascial layer described as? You got my point? If you are doing a laparoscopic repair of hernia, as you raise the peritoneal flap, go down, corresponding to the inguinal ligament anteriorly, there is a fascial condensation of the inguinal ligament. What is that structure called as? That is described as iliopubic tract.
So the iliopubic tract, sir.
Yes, that is iliopubic tract. Suppose this patient has got a hernia in the femoral canal. Where do you find this? Yeah, this looks better. You see, if you go by ABC, now I can see clearly. A
Yes,
is
sir.
in the midline. What is this?
So
The A
is the
is
medial umbilical. So the
yes.
medial umbilical
B
ligaments.
B
B
is
is the medial umbilical ligaments and C
and
is the
C
lateral
is
umbilical
yes.
ligaments.
And as I said, the area between the median and the medial umbilical ligament is the supravesical fossa. Area between the
Yes, sir.
medial and the lateral umbilical is the medial inguinal fossa, and
Medial
lateral is
inguinal
the
fossa.
lateral inguinal fossa.
Lateral
And
inguinal
if
fossa.
you raise the peritoneal flap, structure corresponding to the inguinal ligament from interior will be seen as iliopubic tract. And if you
Iliopubic
have
tract.
a gap in an area, you would say it is a femoral hernia. Where
Behind
is
the
that gap?
iliopubic tract, sir.
Where the gap will be?
So it will be
Between
behind the
the-
iliopubic tract, sir.
It will be more medial. It will be medial to the deep large vessels going, and it will be an area between the iliopubic tract and posteriorly Cooper's ligament,
Cooper's ligament, sir.
and medially lacunar ligament.
Yes, sir.
Medial will be the lacunar ligament.
Okay.
Okay, chalo, next.
Now, next photo clear. Okay. Now, carefully see.
Yeah.
And the different one is
Yes,
A, one is B. Among the region A, B, C. Identify all the things.
Sir, the area A is the
We are
triangle
looking
of
from
pain,
interior.
sir.
Okay, we are looking from the interior. So area A is between where? Between the lateral umbilical ligament and the medial. So this area, as I said, is medial inguinal fossa, through which direct hernia has come up.
Medial inguinal fossa, sir. A is medial inguinal
Yes.
fossa.
Yes. And
Sir, the area
if you
B is
come-
the triangle of doom, sir.
yes. Triangular dome boundary is what?
B
What are the
is the
two
triangle
structures
of
shown
dome.
on either side? The boundary is
Sir,
what?
the vast deferens and the the vast deferens and the testicular vessel, sir.
And this is a line joining the peritoneal surface. That is the, what is the triangle shown as C?
And the line joining the peritoneal surface.
Area
So that
shown
is the
as C.
triangle of pain.
Yes. Why it is called triangle of pain?
Sir, the triangle of pain, sir.
Why
Sir,
it is called
because
triangle of
it
pain?
has sir, if tackers are applied in that area during laparoscopic
Why?
hernia surgery, it will lead to chronic
So
pain.
what may get
of nerves,
trapped?
sir.
What structure may get trapped which will cause pain? There are two nerves going in this area.
So lateral.
Lateral
lateral
cutaneous thigh
femoral
and
nerve.
medially femoral branch of the genitofemoral nerve. Okay, so these two nerves are there in this area. So if you tag in this area, there may be chronic neural pain. That's why this is known as a triangle of pain. And if you now, you see, there is an area shown as D, which is behind the or below the, what is that area? Area shown as D. And while doing inguinal hernia, it
So
is,
the obturator fossa.
yes, that is the area of obturator foramen.
It's known as circle of death or corona mortis.
Where is corona mortis?
Yes, sir.
While
Corona
doing
mortis.
inguinal hernia, you should be cautious to have an idea about the area where you may find abnormal vessels. Where from these abnormal vessels comes?
Sir, there might be a pubic branch arising from the obturator artery that will cross over the lacunar ligament.
One is obturator artery. There may be an abnormal obturator artery which is making
Yes, sir, aberrant obturator artery.
a anastomosis with the obturator artery around the pubic arch, around the superior pubic arch where the Cooper's
sir.
ligament is. What is the lighthouse described in laparoscopic inguinal hernia repair? What is the structure is described as lighthouse?
Sir, in case of transabdominal preperitoneal inguinal hernia repair, when we clear the cobweb areas.
No, not only TAPP, in both.
Sir,
in
the
both
Cooper's,
TAP,
yes, sir.
what is the structure?
Sir, the Cooper's ligament is the lighthouse. Cooper ligament, sir.
Yes. Once you find a pubic arch with Cooper's ligament, that is we described as a lighthouse. Okay.
Lighthouse sign.
This is the lighthouse.
You see. Yes. Once you start describing, you find a shining structure coming up. This comes up both in TAP and TAPP. And if you have a abnormal vessel in this area, what precaution you should take? You should try avoiding injuring these vessels.
Sir, we will,
because if these vessels are injured,
yes, sir,
then it's very difficult to control the bleed and it may be a cause of death event because of bleeding. So that's why it's known as a circle of death.
So next slide.
Circle of death.
So you can read out this. So
just read this.
So the triangle of Doom is a triangle bounded by the medially by the vas deferens, laterally testicular vessels, and inferiorly peritoneal fold. The importance of this triangle is in this area you can find the external iliac artery and vein. The triangle of pain is bound by iliopubic tract superiorly, medially the testicular vessels, laterally peritoneal fold. This triangle holds the lateral femoral cutaneous nerve and the femoral branch of genitofemoral nerve and the femoral nerve.
Yeah. And the trapezoid disaster is? If you take these two triangle and
triangle of Doom plus
trapezoid,
triangle of
these
pain
include
both.
Triangular Doom plus triangular pain combined is known as trapezoid of disaster.
Yes, sir.
Okay, we are moving on.
Okay, Nitesh, come Nitesh.
So this is on the Hasselblad triangle. I'm moving on.
Good, Kamal. Thank you.
Thank you, sir.
See the pictorial diagram and then I'll show the video. Okay, this is the pictorial one, and now the video.
Just see the video and then we'll put some question on that. What is the procedure shown?
So it is abdominal preperitoneal recurrence.
So this is the surgery shown is a transabdominal preperitoneal repair for inguinal hernia. Number one. This peritoneal flat incision starts from where, ends medially where? Just medial to scientific. And then where does it end? The medial side. You should not go beyond medial umbilical. Okay, so don't take this. Once you have taken the incision, what should be the relation of this incision to the hernial bulge? If you start coming from the lateral side, the hernia will be in between. So what is your incision going into the hernial sac itself? 2 centimeter above the hernial sac. Otherwise, you cannot dissect the hernial sac. Okay. As you go medially, a shining structure is coming up. What is that? This shining structure.
That's the limit. This one, just this one.
Cooper's ligament.
Cooper's ligament. In an ideal situation, if you are doing a unilateral hernia, how far you should dissect medially? You have gone to the medial umbilical ligament. How far you should dissect medially to place the mesh comfortably? What is the relation to the midline? If you are doing unilateral hernia, will you cross the midline or don't cross the midline? It has to cross the midline. Ideally, this dissection should just go beyond the midline. Okay, so that is a lateral. Now, once you are raising this peritoneal flap, what are the landmarks you look at while raising the peritoneal flap? What structure comes laterally? What structure comes medially? What structures come in between? While raising the peritoneal flap, important landmark comes lateral, in between, and the medial. Medial, we already said, is that? Medial is a Cooper's ligament. Yes. Laterally, what structure comes? No, what structure comes? You see, these are boundary of the myocardial the fissure. That is ileus vas. Ileus vas. And in between is what? Hernial sac. In between the hernial sac. So these are 3 important landmarks one should look at while doing a TPP repair. How far you should dissect? As you are raising this peritoneal flap, there is a limit to this medial dissection the floor. How far you should dissect? So that the mesh stays comfortably as you place the mesh and try to close the peritoneal sac. What is the landmark? What happens to the deep ring? In the region of deep ring, the testicular vessel and the vas emerges. So, and then you have to keep on dissecting a little higher up. How far? What is the classic? That is a classic description. You have to write that down. The proximal dissection should be at the point where the vas turns towards the pelvis. Okay, as the vas is coming with the somatic cord structures, beyond the deep ring, it deviates from the somatic vessels. And the point where the vas turns medially to go into the pelvis is the point. Is approximately 5 centimeters from the deep inguinal ring. If you don't do this dissection, you may not place the mesh properly in this area. Okay? Where do you fix the mesh? In TAPP repair, as you place the mesh, where you tack or suture the mesh?
Cooper's ligament.
Cooper's ligament. Yes. One fixation may be enough. Or if you need at all, you can fix towards the upper level in the upper border of the mesh. Don't tack any mesh beyond the inferior vessels. Okay, so you can tack 1 or 2 on the medial side.
And one more question: what is this space known as?
Space of
There is no.
Space of Regius is when you bring the bladder down, the area between the symphysis pubis and the bladder is known as space of Regius. And if you come to the lateral side from this, it is described that there are 2 layers of fascial vessels. The structure deeper is the peritoneum. And these 2 layers of fascial vessels is the structure which the deeper layer gets blended with the peritoneum and the anterior layer remains in the parietis. If you can dissect in between these 2 layers, you are in the avascular space.
Yes, that should be.
This is described as space of Bogrov. This is described as space of Bogrov. So, you see, this clipping will be shown and there will be 3 or 4 questions you have to answer specifically. And maybe that some structure will be marked with this ABCD and then the extent of
These are put us.
Okay.
Also ask.
Yeah.
Video. Now, look at this.
Wait, let this whole thing run. Okay, you have seen this. The specific question.
Keep this total extraperitoneal repair total.
Total extraperitoneal repair for inguinal hernia, number one. The port that was made is where? The first port that was made is the port made in which location?
It is umbilical.
Infraumbilical. And as you made this port, what structure you incise and then you insert the trocar or the benule, whatever it is. What you do? Up to which level you incise? Up to which level you incise to go into this area?
Up to, sir,
you are creating a preperitoneal space. So there is something to say that you keep on incising the structure and then go to the particular space. What to incise? As it was done initially. Skin, subpinal tissue, and anterectal sheath. And then what do you do? Retract the rectus muscle laterally. As you incise the rectus sheath, retract the rectus muscle laterally. Now, question is, you need to create a preperitoneal space. There are two ways to create a preperitoneal space. One is, what is this? They have used a balloon. One technique is to pass a balloon, inflate it. What is the other technique people are using? Apart from using a balloon? Optical tackle, the access. How do you create this space? Yes, insufflation. Insufflation. Either use a balloon to create the space, or as you go into this area between the rectus sheath and the rectus muscle in between, you start insufflating. As the carbon dioxide goes, it can open up. In TP, you can do groin hernia repair. What is one contraindication for doing TP repair? Where TP is not advisable? In which inguinal hernia, you should not attempt to do a TP. Strangulate, even in TAPP is contraindicated. Strangulated hernia, unless you are very expert, then you should not go at all. Even an irreducible hernia is a contraindication for TP. A irreducible hernia or obstructed hernia, you can manage with TAPP. But TP, it is difficult to reduce the irreducible hernia. So that is one of the situation you should not attempt for a TP repair. While doing TP repair, what should be your extent of dissection? Is it different from TAPP? It's not different. Because the only difference here is, in the first case, you are going transperitoneally, and then inside peritoneal flap, you go to the preperitoneal space. Here, you are going directly to the preperitoneal space. So, extent of dissection will be same. You have to dissect laterally up to the anterior suprailiac spine. Medially, you have to go beyond the midline. Below, you have to go up to the Cooper's ligament. And above, you have to dissect 2 cm above the sac. That is a complete sac. The sac was going to the scrotum. How will you manage the complete sac?
So complete sac, sir, we cannot reduce English, sir, so we'll divide the.
How can you divide? What is the technique? If there is a complete sac, what step you should take?
So we
have seen
the contents.
Yes, the content is reduced and you dissect the sac. You dissect the sac to some extent and then make a tunnel around the sac. You ligate the proximal part of the sac and divide, keep the distal end open. So if it's a complete hernial sac, it is difficult to deliver the fundus into the site. So don't attempt. It will cause more bleeding. It will cause difficulty in dissection. In TEP repair, why do you fix the mesh or don't fix the mesh? In TEP repair, some people are in TEP repair, place the mesh, its handle between the wall and the. I think 9-5. We can close today. We will take another day for hernia. Maybe winter hernia, another time. No, not we'll take another day. Huh? We will review what we have covered. Maybe that we add some more picture to the hernia and then. Any question? Anything in the chat box? People are asking some question in the chat box.
So mostly.
You see, what is that is the important question. What is the modification basin repair? You see, original basin repair was taking the internal optic, transversus, and the first mesh, all layers. But in take the conjunct tendon and the first transversus. That is the modification.
The mesh is placed.
Where is the mesh?
In TAP, the mesh is placed in the same place as you in TAP. Medially, the mesh should go just beyond the midline. Laterally, it should go just medial to the anterior spine. Below, it mesh should overlap the Cooper's ligament, and above 15 cm mesh as it go up beyond the ring. We'll take another day for remaining part of groin hernia and the winter hernias, because there are a lot of things in the winter hernias. Okay. If there is no other question, you can conclude today. Thank you all. Thank you. Thank you, Kamal.
Thank you, sir.